Good afternoon, everyone, and thank you for joining us for our webinar today. I'd like to put a special thank you to everyone who makes these Project Echoes a success. A special thank you to our librarian, Dr. Stewart, who will be providing some citations and information in the chat. You may also, if you have any questions at any point, you can stick them into the chat and we'll kind of follow up with them at the end of the presentation. Also, a special thank you to Dr. Ariel Santos, who is a PI for TexLa, and Dr. Phillips, who is our champion for rural health and our fearless leader. And thank you to all of you who have come and wanted to take part today in this presentation. As you may know, June is Alzheimer's and Brain Awareness Month, and we are delighted to welcome Dr. Nicole Purcell as our speaker for this afternoon's webinar. She'll present on dementia care in the era of telemedicine, taking a clinical perspective from rural America, and we'll have time for questions and discussions at the end of her presentations. We will have a few introductions and housekeeping slides, and then we'll jump right into the presentation.
All right, so this educational activity is a project of TexLa Telehealth Resource Center, a federally funded program with the F. Murray Hall of Rural and Community Health at TTU-HSC, as well as Well Ahead, Louisiana, with generous support from the Health Resources and Services Administration, or HRSA. Next slide. And just a reminder that CME credit is available for participants of the webinar, and a link to take that survey will be provided at the end of this presentation, as well as emailed to all attendees. And then these are just some helpful tips for our webinar. Please do make sure everyone is muted, and please type any questions or comments you may have during the presentation into the chat box, as those will be addressed later after the presentation. And Derek will now introduce our speaker.
Dr. Nicole Purcell is a general neurologist and senior director of clinical practice in the Alzheimer's Association, where she is a leader in the creation of clinical content for the education of professionals, health systems, and other clinical audiences. She is also a member of the Alzheimer's Association Innovative Roundtable, where innovators and thought leaders reimagine mechanisms for risk reduction, improving early detection, and increasing access to evidence-based, person-centered care for individuals with dementia. Prior to her tenure with the Alzheimer's Association, Dr. Purcell held a variety of clinical, administrative, and teaching roles within the community and private academia healthcare settings. She engaged patients in the hospital outpatient settings and via telehealth platforms. Since 2011, she's been a driver of telehealth care to reduce disparities in healthcare access, where she developed hospital-based telehealth networks to connect patients with clinical care in which they would not have had access otherwise. Prior to becoming a physician, Dr. Purcell utilized her MS degree in the pharmaceutical industry, engaging in phase 3 clinical drug trials. She continues to maintain a clinical neurology practice within a health system in Pennsylvania. We're now going to hand it over to you, Dr. Purcell, and we're so happy to have you.
Well, thank you. I appreciate being here. I'm just going to share my screen. And you can see my screen and you can hear me okay?
Looks great.
Yes.
Thank you.
Okay, perfect. So let's get started. So I don't really need to introduce myself, since there was a really nice introduction already there. I have nothing to disclose, and the objectives of this is really to understand dementia care, especially in the rural setting, and with regard to using telehealth to try to close any gaps that may exist. So the first thing I want to talk about is epidemiology. So Alzheimer's disease is a leading cause of dementia. Not all dementia is Alzheimer's disease, but about 60 to 80% of cases is Alzheimer's disease. More than 6 million Americans are living with Alzheimer's disease in the United States, more than 58 million worldwide. About 1 in 3 seniors will die as a result of Alzheimer's disease, and it actually kills more people than breast cancer and prostate cancer combined. The biggest risk factor for Alzheimer's disease is age. So as people age, Alzheimer's becomes more prevalent. So about 1 in 9 people over the age of 65 will have Alzheimer's disease. And you can develop Alzheimer's disease at a younger age, younger than 65, but it occurs much less common. So what we do know is that gaps in diagnosis of dementia will lead to gaps in care. So I'm hoping I'm going to be able to close some of those gaps with this talk today. In looking at the data, and the data I'm going to share with you comes from the Alzheimer's Association Facts and Figures report. And if you're not familiar with the Facts and Figures report, it's a report that the Alzheimer's Association releases every year. And it really gives you an idea of the landscape of dementia in the United States from year to year. It's free, it's on our website, you can download it. Some data, 98% of primary care physicians feel it's important to diagnose mild cognitive impairment. 96% of primary care physicians feel it's important to assess patients age 60 and older for cognitive impairment, but they report only conducting assessments in 48% of patients. Now, interestingly, when I saw this data, I thought, of course, primary care physicians feel it's important. And of course, they're not assessing these patients because they just don't have time. And when you look at our facts and figures report back in 2019, primary care physicians did report time as being a concern, but most recently, time was not their biggest concern. And I will tell you, CMS has really closed that gap and enabled primary care physicians time to spend with patients, but the codes that are used are very underutilized. So the most frequently cited challenges when making a diagnosis of mild cognitive impairment is actually difficulty differentiating what is normal aging from mild cognitive impairment. Primary care physicians also report difficulty interpreting patient reports of daily function. So what they're doing on a daily basis, is that normal or not? They also report a lack of specialists and facilities to perform diagnostic testing. So what we hear is, why make a diagnosis if I don't have support? If I get stuck and I need support of a specialist or a specialty diagnostic center, I don't have it. And then we know patients are reluctant to pursue follow-up. Some just don't want to engage in healthcare. And primary care also reports reluctance to diagnose a condition that has limited treatment options. And in 2023, we do know that that landscape is changing because now we have 2 FDA-approved medications for Alzheimer's disease. So in looking at who's making the diagnosis of dementia, well, of Medicare beneficiaries, 85% were diagnosed by a clinician other than a dementia specialist. So that's primary care physicians. 15% were diagnosed by specialists, mostly neurologists, psychiatrists, and geriatricians. What's interesting is that 40% of primary care physicians reported that they never or only sometimes feel comfortable making the diagnosis. And 50% felt that they were not really adequately prepared to care for individuals with dementia. So I'm hoping today I'm going to be able to close those gaps because, as you can see from that data, primary care is really on the front lines of this disorder. So when we talk about shortages of specialists, there's about 22 states in the United States that are considered neurology deserts, where there's very few neurologists in the state. And primary care physicians report the shortage of specialists. And you can see, if you look on the left side, 44% of primary care physicians in large cities said that they had a problem connecting patients to specialists with the shortage. And then the further out from the urban areas into the rural areas you go, 71% of primary care physicians reported a shortage of specialists in rural areas. So that's really a significant disparity just in geographic location. So what can we do about that? Well, I will tell you that research supports a collaborative primary care model. So if you can bring a team of healthcare professionals together to care for these patients, you can take care of them even without specialists. So a collaborative primary care model may have a physician included. It may have a nurse practitioner or a physician's assistant, home nursing, social workers to get patients connected to social services in the community. But this collaborative model has been shown to reduce behavioral symptoms, improve quality of life and function for the patient, decrease caregiver burden, and lower costs of healthcare, mostly related to emergency department and hospitalization usage. But so there is data to support a collaborative model. There's also data to support use of telehealth while taking care of patients with dementia. So there was a systematic review of telehealth services as far as routine care, cognitive assessments, and rehabilitation. And it does show that telehealth care can be equivalent, the same as in-person services. So utilizing telehealth care should not be looked at as being secondary to, or we can do this instead of, but it can be just as good as in-person care and more convenient for the patient, their caregiver, not having to travel to an office, especially if living in a rural area where they may have to travel several hours of distance. But again, utilization of team care is really where it's beneficial. And you can see the teammates there: social workers, pharmacists, advanced practice nurses, care navigators. And so why is it so important to actually screen patients and make a diagnosis early? Well, one good reason is Americans want to know. So nearly half of Americans, 47%, worry about developing mild cognitive impairment in the future. And 85% of Americans want to know early in the disease course if they have it. So if you look at the bar graph on the right, 54% of Americans want to know at the mild cognitive impairment stage that they have it, and 31% in the mild Alzheimer's disease course of the illness. And then you get down where 5% never want to know, but a majority of Americans do want to know. Asian and Hispanic Americans are more likely to worry about mild cognitive impairment than Native, white, or Black Americans. So other benefits of early diagnosis, we used to say, why make a diagnosis if there's no treatment? There's nothing to do, but there's really plenty to do. And some of it is really on the patients and their care partner side, and some of it is on the health professional side. So you can identify modifiable risk factors and address them. So it's thought that about 40% of dementia can be prevented or delayed in onset. And if you can delay the onset even for a year, that's a year more that an individual can spend with their family or their loved ones or remaining independent. And that's a huge cost savings to the patient, to the caregiver, and the health system independently. You can evaluate for other causes of cognitive impairment. If you screen and know that they have a cognitive impairment, you can look for other causes of cognitive impairment. Oftentimes, if patients screen positive for cognitive impairment, they can identify a care partner, and that care partner can help them with their comorbid conditions. They'll make sure they're getting their medications and sticking to any care plans that you decide on. It gives the opportunity to discuss new treatments and medications as they become available, and get patients the opportunity to participate in clinical trials. So we have so many clinical trials that are ongoing, especially with regard to new medications, and we don't have enough participants. So we really encourage, especially older individuals, midlife and older individuals, to engage in clinical trials. For as many patients with cognitive impairment, we need patients without cognitive impairment to compare them to. So we do encourage them, and it's really easy to find clinical trials. If you just go to our website at the Alzheimer's Association at alz.org, there's something called Trial Match, and you can put in your demographics, where you live, your age, and where you're at in the diagnosis of things, and they can find a clinical trial that may suit you. By identifying cognitive impairment early, you can do safety assessments. Should the patient be driving? How's their home environment? Do they have grab bars in the bathroom? Have they gotten rid of their throw rugs? Is there any elder abuse? And then really allowing the patient time to discuss what they would like for the rest of their life. So where would they like to live if they advance to a point where they can no longer live independently? Or what does that look like for them? And getting power of attorneys and other legal documents in place. And just knowing the diagnosis often reduces anxiety about symptoms that they didn't know why they were having the symptoms. So when we talk about risk factor reduction, what we know is that what's good for the heart is good for the brain. So if you can take care of vascular risk factors, such as diabetes, high blood pressure, dyslipidemia, smoking cessation, getting diet and obesity addressed if there's any concern there. You want to address all of those things, as well as depression. So we know that depression is linked to dementia, and it's not really clear how. There's some thought that maybe depression is an early symptom of dementia, but it's also, there's some theories out there that depression could lead into dementia. So we really recommend aggressive treatment of dementia in midlife and later life as well. Avoiding traumatic brain injuries and concussions, we do know that they can lead to a tauopathy. Reducing sedentary lifestyle, so getting patients moving. The recommended amount of exercise is 30 minutes a day, 5 days per week. And I tell patients it's as simple as walking down the street for 15 minutes and coming back, and that's your 30 minutes. We do know that not engaging in mentally stimulating activities can be harmful, and then isolation or getting social engagement, not engaging in social activities as much, is also a significant risk factor. So these are the things that you want to try to modify for your patients to decrease their risk by about 40%. When we talk about other risk factors for Alzheimer's disease, there's the unmodifiable risk factors, the risk factors that you can't really do anything about. And age is the most significant risk factor. So the older we are, the more likely we are to have dementia. Family history is another factor that you can't control. And if your first degree relatives, and to a lesser extent second degree relatives, have dementia, it does put you at higher risk, but it doesn't mean you will develop it. When it comes to genetics, again, something that you can't control, we talk about two types of genes with genetics. We talk about deterministic genes and risk genes. The deterministic genes, you may have heard of them, amyloid precursor protein, presenilin 1, presenilin 2. If you inherit one of those genes, you will develop Alzheimer's disease. And these deterministic genes are really associated with individuals that have onset less than the age of 65. And once you have one of these gene mutations, you will get the disease, and you have a 50-50 chance of passing that on to your offspring. I also want to mention about trisomy 21 and Down syndrome. Those individuals will develop Alzheimer's disease earlier than the typical American. And so usually by the age of 40, many patients with Down syndrome already have a significant amount of tau and amyloid pathology already accumulating. When we talk about risk genes, this means that the patient and the individual may or may not develop the disease. So because you have an at-risk gene, doesn't mean you will get it, doesn't mean you won't get it if you don't have that gene. And there may be dozens of these genes out there, but the most common one that you may have heard of is ApoE4. So we inherit a copy of ApoE from each of our parents. So we have 2 copies. If you inherit 1 copy from a parent and you're heterozygous, your chance of developing Alzheimer's increases. If you have 2 copies of ApoE4, 1 from each parent, your risk is even higher. But again, it doesn't necessarily mean that you will deliver or that you will develop the disease. And I'm going to talk about this again in a little bit. So when a patient comes to you and says, you know, I'm having difficulty with my memory, what you want to do is rule out dementia mimickers. So things that will cause cognitive impairment, but might not be dementia. So we do know that depression can do that, infectious etiologies such as Lyme disease, meningitis, encephalitis, vitamin deficiencies such as thiamine or vitamin B1 or vitamin B12, thyroid dysfunction, excessive alcohol use, side effects of medication. So you want to take a look at their medication list and get rid of any medications that may be causing cognitive dysfunction. Delirium can do it, and obstructive sleep apnea is really becoming spotlighted. Recently, there have been some studies showing that patients with untreated obstructive sleep apnea do have significant cognitive impairment and difficulties with thinking. So we really want to get these patients identified and treated. So I want to show you this graph because this graph has been around since about 2010, and it's really quite a telling graph. So if you look at the x-axis, this is the clinical disease stage. So on the left is normal, and then you advance into preclinical, mild cognitive impairment, and the dementia state. And if you look at the y-axis, down at the bottom is normal, and up at the top is abnormal. And if you look at this red line over here on the left, the first wave here, this is amyloid accumulation. So if you look, amyloid is accumulating when the patient is still in the normal and preclinical phase, and they really develop a maximum amount of amyloid that they're going to develop and deposit really early in the disease before they hit the mild cognitive impairment stage where they start to show symptoms. So this pathology is going on, we think, for 10 to 20 years before you start to show symptoms. If you look at the next line over, this is synaptic dysfunction. So where the synapses between the brain cells, they're having a hard time transmitting their signal. And again, there's still a pretty significant amount of synaptic brain dysfunction going on before the patient reaches the mild cognitive impairment stage. And then the green line is tau. So you still have about half the amount of tau you're going to accumulate before the patient gets symptoms. The blue line is MRI changes, so showing atrophy on MRI. This all occurs in the normal to preclinical phase before the patient has symptoms. And then this purple line is the line that shows when the patient is starting to have cognitive concerns, cognitive symptoms. And then the line over to the right is really when clinical function starts to get involved. So my point in this is the newer medications that are FDA approved are anti-amyloid monoclonal antibodies. And the reason they targeted amyloid is because all this amyloid seems to accumulate, and it seems to be the initial pathology to trigger this cascade. So the hope is that these anti-amyloid medications, if getting rid of amyloid, maybe we can stop the development of the disease. And I can talk more about that later when we talk about the medications. So let's talk about what is mild cognitive impairment. I've been throwing that term around, and I want you to know that no memory loss is typical, and it's always pathological. As we age, our thinking and our cognition may change, it may slow, we may have harder time retrieving information, but memory loss is never normal. And mild cognitive impairment is really characterized by subtle changes in memory and thinking, and it's a broad set of symptoms. I also want to note that mild cognitive impairment can be due to Alzheimer's disease, but it can also be due to other etiologies besides Alzheimer's disease. So if you have mild cognitive impairment, so changes in memory and thinking with a biomarker evidence of brain changes of Alzheimer's disease, we call that mild cognitive impairment due to Alzheimer's disease. If it may not be due to Alzheimer's disease, we just call it mild cognitive impairment. Individuals with mild cognitive impairment may have a higher risk of developing dementia. About 10 to 15 patients 10 to 15% of patients will advance to dementia per year, but not all of them do. So some of them do, but not all. And then what's the definition of Alzheimer's disease? Well, it's a decline in memory and learning and one other cognitive area. And that could be another area of cognition. It can be behavioral symptoms or neuropsychiatric features, but it's characterized by a steady decline without periods of stability. And the cognitive symptoms should not be related to another medical problem, neurological problem, or psychological problem. And as you know, Alzheimer's disease is a continuum. Patients will start out asymptomatic, and then they'll develop mild cognitive impairment due to Alzheimer's disease. And then when they hit the Alzheimer's disease stage, they'll go through mild, moderate, and severe stages. So what is normal aging? I do want to take a few minutes and talk about what's normal aging, what's mild cognitive impairment symptoms, mild to severe Alzheimer's disease. So normal aging, we all forget why we walked into a room. We all forget where we left our car keys. We all forget appointments from time to time. But the point is that we remember these things later. We may have some difficulty with word finding. We may have some difficulty managing finances, paying bills on occasion, but we can generally manage these things independently. We may have some visual changes related to cataracts, but no visual field cuts. We may start to withdraw from family and social obligations because we just don't feel like going, but this is occasionally, and we may become irritable. These are all normal symptoms. With mild cognitive impairment, the decline is greater than what is expected for age. And these declines usually do not affect the ability to engage in activities of daily living. And that's really the difference between mild cognitive impairment and mild Alzheimer's disease, is if you can still engage your activities of daily living and you have cognitive concerns, you're in the mild cognitive impairment stage. Once you start to need some support for activities of daily living, now you've crossed over to the Alzheimer's stage. I do want you to know that in the early stages, the mild cognitive impairment stage, cognitive assessments that you would do in the office are often normal. So the mini mental status exam or the MOCA, they're not really sensitive enough to pick up on mild cognitive impairment. So they may be testing normally, and you may need a neuropsychological evaluation to really tease out what the nature of the cognitive concern is. And over a 5 to 10 year period after having a diagnosis of mild cognitive impairment, 30 to 50% of those people will progress on to dementia. So in the earlier mild stages of Alzheimer's, patients can really still function independently, but they do require some assistance with their activities of daily living, but they may continue to drive and work depending on where they're driving to and the nature of the work that they do. But you'll find that they're starting to misplace items and they're having difficulty retracing their steps. They may have more difficulty with word finding, forget to take their medications or pay their bills. They have difficulty performing in social and work settings where they have performed, normally and well for most of their life. They may start to forget things that they read, and they stop reading because they can't comprehend what they read last. And they may start to experience some psychiatric symptoms that they never had before. Depression, anxiety, and social withdrawal are very common at this stage, as well as difficulty with sleep, and they may develop some irritability. As they progress to the moderate stage, everything that they were experiencing in the mild stage tends to get worse in the moderate stage. And we know that people spend most of their time in the moderate stage of their disease. So now they're starting to have difficulty completing multi-step tasks. They may be becoming confused and disoriented. They may have some weight loss because they have decreased appetite. Incontinence becomes common. They may start to have seizures or extrapyramidal symptoms such as bradykinesia or slowing of movements. They may start to wander. So if the patients are wandering, they're at least in the moderate stage. They may start to have difficulty navigating familiar environments or cooking. They can't remember what ingredients to put in. They can't remember leaving pots on the stove. This is all in the moderate stage. And as they progress to severe or late stage, their language becomes more affected, where they may have global aphasia, where they don't understand what you're saying to them and they can't express what they're feeling. They may require around-the-clock care. Their gait and their balance is really impaired. And they may start to forget their family members, their children, their spouses that they've lived with for most of their life. And death usually happens as a result of aspiration because of dysphagia. Now, I know this looks like a busy slide, but the slide was meant to be all on one slide so that you can take a picture of it and look at it later for reference. But what I do want to bring to your attention is I'm going to briefly go through these other forms of dementia so that when you're seeing these individuals, you can be thinking about other things besides Alzheimer's in case that comes up. And I also want you to know that if you see a neurologist report or a neuropsychologist report where they feel that the patient has a mixed dementia, what they're actually saying is that the patient has more than one type. So because a patient may have Alzheimer's disease doesn't mean that they won't develop vascular dementia, especially in our country where vascular dementia is so prevalent. It's common that we see more than one type of dementia, and vascular dementia is a prominent one. So with vascular dementia, we really see two phenotypes of symptoms, and one of them is a stepwise decline. And that occurs with stroke. So the patient may be going through life, they have a stroke and their cognition declines and they never get back to where they were previously. And then maybe they have another stroke and they take another decline in cognition with that and they never get back to where they were. So that stepwise decline can be vascular dementia. The other thing we see is with older folks, as they develop that chronic small vessel white matter disease that we see on so many MRIs in older folks, as those MRI scans progress with regard to that white matter disease, that white matter disease is a result of hyperperfusion from tiny penetrating blood vessels deep in the brain. So as they accumulate those white matter changes, they will develop more gradual decline in cognition. So that's the two ways that we see vascular dementia. And to try to avoid vascular dementia is modifying those vascular risk factors, and blood pressure is huge. So if there was one risk factor that you had to change, it would be keeping blood pressure generally less than 120. Okay, so dementia with Lewy body, I'm going to talk about that in relation to Parkinson's disease dementia because they are similar. Dementia with Lewy body, I describe to patients as being almost a combination of Parkinsonian symptoms and Alzheimer's disease. So patients will develop this gradual decline in their memory, and they'll have these superimposed episodes of worsening symptoms. And they will develop the cognitive symptoms usually a year before the motor symptoms develop. And when they develop the Parkinsonian symptoms, they don't really get that characteristic tremor that we all know with Parkinson's disease, but they get more tremulous or shaky. They have a lot of stiffness, a lot of falls, a lot of autonomic dysfunction and syncope. And these patients in particular become very sensitive to medication. So we try to de-escalate and discontinue as many medications on these patients as we can. With Parkinson's disease, usually the motor symptoms, so that characteristic tremor, the shuffling gait, the hunched over, that usually occurs about a year before the cognitive symptoms develop. And in Parkinson's patients, about 50% will develop cognitive symptoms. So the other 50% does not. So if you have Parkinson's disease patients, you may want to screen them for cognitive symptoms. And then frontotemporal dementia, you may be aware of that, of frontotemporal dementia, as Bruce Willis's family came out earlier in the year and announced that he was diagnosed with frontotemporal dementia. And there's really three phenotypes we see with that. And one of them is called primary progressive aphasia. And that's the one that Bruce Willis has, where they start to lose their language ability. They have word finding difficulties. They can't retrieve words. They get to a point where they can't understand speech. And then the other phenotype we see is called behavioral variant, where patients have a lot of personality changes, a lot of aggression. They may have stereotypical speech patterns or repetitive movements. That's the second type of phenotype. And the third phenotype we see is with ALS. So patients with amyotrophic lateral sclerosis or Lou Gehrig's disease, we used to think that they would lose muscle and motor control and just gradually become weaker in their body, but retain their cognition when, they oftentimes will develop frontotemporal dementia. Frontotemporal dementia generally develops earlier than Alzheimer's disease. So these are patients that generally start to have their symptoms between the ages of 45 and 65. So if you're seeing a patient younger than 65 and they have cognitive impairment, the question is it Alzheimer's disease or is it frontotemporal dementia? So I just want you to be aware of these other differentials. Not everything that's dementia is Alzheimer's. So I want you to be aware of those. So who should be assessed for cognitive changes? Well, anyone that comes to you and says, I'm having problems with my memory and thinking, or if a care partner or someone close to the patient brings that concern, you want to assess them. Any Medicare beneficiary as part of an annual wellness exam, you do need to screen for cognitive changes there. And then there's some non-memory concerns that really should pique awareness that maybe you need to assess cognition. If patients are having a functional decline or they're falling and having balance issues, or they have a deterioration in their chronic illnesses without an explanation, these are reasons that you would want to see if they have cognitive concerns underneath. They may not be taking their medications. They may not be adhering to whatever care plan you set in place. If patients are developing depression that they never had before, personality changes, you want to screen those patients and assess them. The United States Preventive Service Task Force, you're probably very familiar with them. They looked at data to see, should we be screening all patients at a certain age, over the age of 65, for cognitive impairment? And their conclusion on 3 occasions with very good evidence, a lot of studies, was that there's insufficient evidence to recommend for or against screening for cognitive impairment in asymptomatic community dwelling adults age 65 and older. So if the patient is living independently and doing well without complaint, you don't necessarily need to screen them unless they're a Medicare beneficiary, then you do. So as part of the annual wellness visit, you may know that CMS says they want you to detect cognitive impairment, but they don't tell you how. They don't tell you you have to use a certain screening tool, but they say that direct observation can be done and that can be well enough. But we do know that the Alzheimer's Association convened a work group to look at that. And what they found is informal observation is not good enough. That if a primary care physician uses some type of screening tool, you can increase the detection rate of cognitive impairment to 83% versus 59% by observation only. So what you want to do is pick a screening tool, and I'm going to go over them, but it should be something that takes less than 5 minutes, because primary care physicians do not have time beyond that, and it should be free. It should be validated in the appropriate setting if it's primary care or whomever is doing it, and it can be administered by staff. It doesn't necessarily have to be administered by the physician, and it should be free of cultural bias. Now, one thing I do want to point out, when I was talking about getting care covered, Medicare does allow you to take care of these patients. So if a patient says to you during a routine, maybe an acute visit, or you're walking out the door with the patient and they say, by the way, I have some memory concerns, you can bring the patient back into the office for what we call a comprehensive care planning visit. And the CPT code you're going to use is 99483. And this allows you to have 60 minutes with the patient, so that they reimburse, CMS reimburses, I think, $283 for that hour. If you use that 99483 CPT code, if you need 100 minutes to see these patients, you can add a G modifier of 2212, and this is all legal. But I will tell you that there's 2 caveats with this care planning visit. It must result in a care plan that meets moderate to high level decision making. So you need to review medications, safety, any psychiatric or behavioral symptoms, identify a care partner, and the visit must include an independent historian. But CMS does allow, if the patient comes to the office by themselves, you can call an informant on the phone and get additional information. But that buys you 60 minutes to see this patient. So cognitive screening tools. So there's literally hundreds of these out there. I'm just going to show you 4. They're well validated. And I'm going to just point out 2 of these. But I do want you to know that these that I'm showing you, they can be done by telehealth. So I can even do a mini mental status exam by telehealth. I've been doing it since 2011. But I'm going to point out the MiniCog, very simple screening tool that you can use. And it seems very popular. When I talk to primary care physicians, they often use this one. And what it really is just a 3-item recall. Give the patient 3 words to remember, and then have them draw a clock, put the numbers inside, and place the hands to indicate a certain time, like 10 after 11. And then when they're done drawing the clock, you have them recite those 3 words. So whenever I'm seeing a patient by telehealth, usually by video, my staff knows to let the patient know, when you log in, make sure you have a pen and paper or pencil and paper, because I'm going to tell them I want them to draw a clock. Or if I'm doing the mini mental status exam, I'm going to have them write a sentence, and I still have them draw a clock, but I have them do some things that I can watch them do remotely. The other screening tool I want you to be aware of is the AD8, which is down here in the right corner. Sometimes patients don't want to engage in cognitive evaluations. They don't want to do these silly little memory tests, they tell me. You can do the AD8 with an informant, so a spouse, a child, someone, and you can do this over the phone. It can be done in the waiting room. So it can be done by the patient or by a care partner if the patient doesn't want to engage. And then the other cognitive assessment tools, these are the ones that I would use, but they take about 15 minutes, and you don't have time for that unless you're going to use the comprehensive care planning visit that we talked about. But I do want you to know some caveats with these. The mini mental status exam is really not good at detecting mild cognitive impairment, as I mentioned earlier. It is widely used in research studies, but there is a fee to use it. So it is copyrighted, and I think the fee is $1.25 every time you use that test. So it becomes cost prohibitive to a lot of health systems. The MOCA now has a 1-hour training certification video they want you to take, and I think that's $150 to take that. So there's fees associated with those, and then the slums is free, but I want you to be aware that that was validated mostly in the Veterans Administration, but a lot of doctors and health systems started to use the slums because it's free. So when you're seeing these patients and you see something that doesn't seem quite right, and you want to refer the patient to a specialist, some guidance on what may raise a red flag for you. If you're unsure of the diagnosis, certainly refer the patient on. If there's an atypical presentation, so they're younger than 65, if their symptoms are acute or subacute, you may want to get them to see a neurologist. If their predominant symptoms are behavioral or psychiatric, If they're having seizures, refer them on. If the family prefers to see a specialist, refer them on. Or if you yourself wants a second opinion on behalf of the patient, certainly refer them on. So in looking at a pathway, so you're going to see the patients, do a history and physical with a cognitive assessment, and you can usually characterize the patient as being unimpaired, maybe mildly impaired or severely impaired. And then you want to do some laboratory studies and the standard labs, CBC, CMP, TSH, and vitamin B12. Brain imaging is also standard. An MRI is ideal, but if there's a contraindication, you can certainly get a CT scan of the head. And then depending on your comfort level with the diagnosis, you'll either take care of them or you'll refer them on to a specialist. And there's some other laboratory studies you can consider, depending on the patient's risk. You can do things like a hemoglobin A1C, ammonia if there's liver disease, or Lyme, depending on where you live. You can rule out infection with a urinalysis or a chest X-ray, and then evaluating for sleep apnea or an REM sleep disorder with a polysomnography examination. And then in thinking about what specialists you're going to refer patients to, your choices, really you need to know the landscape in the area that you're practicing. They may be neurologists, geriatricians, psychiatrists, and even a neuropsychologist is helpful without the other specialists, because a neuropsychologist can really give you a good evaluation of the patient's cognition. They generally see one patient a day and they examine the patient for 2 to 6 hours doing different cognitive tests, and they usually give you a really great report when you're done, and they give recommendations. So I want to talk a little bit about biomarkers, since I get a lot of questions about this. So biomarkers are on the horizon right now. Currently, we have PET scans that can detect amyloid and tau anywhere that PET scanning services are available. So if you work in relation to a cancer center, they may already have PET scanners available, and you can order that. The only problem with PET scans is that insurance companies are generally not reimbursing them. And if one of the health systems told me their PET scans cost anywhere from $2,000 to $10,000 out of pocket. We have, and they are FDA approved, the PET scans. The other FDA approved tests are CSF biomarkers. So you can send your patient for a lumbar puncture for CSF analysis. And there's at least 2 tests that are FDA approved on cerebral spinal fluid. This is usually reimbursed. Insurance companies will pay for the lumbar puncture. The only problem is it is invasive. The other problem is, before you send a patient for a lumbar puncture, you want to alert the lab wherever the spinal fluid is going to go, that you're going to order an Alzheimer's panel, because they're going to have to send that to a reference laboratory, and they usually need a kit of special tubes. So just let them know, they'll get the tubes and they'll send them wherever, whoever's doing the lumbar puncture. So that's an option. Plasma markers are not FDA approved. There are some laboratory tests that are CLIA approved. I see some of the commercial labs that do have CLIA approval, but they are not FDA approved. Some of their validation studies use very few patients, so they don't have a whole lot of scientific data to support the blood plasma levels. In talking about genetic testing, so you can order a genetic test, especially on patients that are younger than the age of 65, where this would be most prevalent. And you can order amyloid precursor protein, presenilin-1 and presenilin-2. But remember, if you have that gene mutation, you are going to get Alzheimer's disease. So the Alzheimer's Association, we generally recommend not doing that panel on patients until they've been in contact with a genetic counselor, so that they understand the social and economic implications of knowing that information and having that information in their medical record. Same thing with ApoE testing. You can get ApoE testing. You can order it at places like 23andMe. And we discourage individuals from doing that until they've talked to a genetic counselor, so they know that although you may have, maybe homozygous and have 2 copies of ApoE4, increasing your risk, you may not develop the disease. It's also good to know that this APO testing has been studied mostly in Northern European ancestry. And so we really need to do more studies in a genetically diverse population, such as we have here in the United States. Now, I will say ApoE testing may become more common, there is a side effect associated with the newer monoclonal antibodies called ARIA, amyloid-related imaging abnormality. And it seems to be the patients will develop this side effect, and I'm going to talk about what the side effect is in a minute, if they're ApoE4 positive. So some of these treating physicians may actually order an ApoE test, and it's to risk stratify their chance of developing ARIA. So when we talk about FDA-approved treatments, we have the acetylcholinesterase inhibitors and the glutamate regulators, and I'm not going to spend very much time talking about them because they've been around at least since 2005. So we're all pretty familiar with them. We know the donepezils, rivastigmines, galantamine, and memantine. I do want you to be aware that there's a combination pill of donepezil and memantine called Namzaric, and that will reduce the number of pills and times that the patient needs to take the medications if they're on donepezil and memantine, but it's poorly covered by insurance. I find that patients say that it's still very expensive, and we end up breaking the pills down into their separate prescriptions anyway. So the monoclonal antibodies, there's actually two that are FDA approved. Aducanumab was approved in the summer of 21, and lecanemab was approved in January 23. And these are monoclonal antibodies aimed at amyloid. So they do an excellent job at clearing amyloid. One of the main side effects you'll hear about is this ARIA. And the amyloid-related imaging abnormality really results in two types of abnormalities: brain swelling and hemorrhages. Now, usually these side effects, the ARIA side effects, occur within the first 3 months of treatment. These are IV infusion medications. And during that time period, there are frequent MRIs that are captured. For many of these cases, the patients were asymptomatic and picked up on MRI scanning. So there are appropriate use recommendations that have been published and do have open access in journal for you to go ahead and look at those appropriate use recommendations. Or if you want them, I'm happy to email them to you. But looking at what's actually the recommended use of these monoclonal antibodies. And so now some non-pharmacological approaches, especially with regard to behavior. You want to keep routine very daily. Patients with cognitive decline, they thrive on daily routine. They need regular sleep. It is thought that amyloid gets cleared when we sleep. So sleep is very important, especially in midlife when you may start to be accumulating amyloid. So regular sleep, getting patients moving and exercising. Exercising does improve cognition. It improves volume in the brain. It improves symptoms of depression and does assist with sleep. So I cannot emphasize exercise enough. You want to decrease sensory stimulation. They're just like kids. You know, when you're at a party and there's a lot of stimulation, it gets very overwhelming. You want to reduce triggers for unwanted behavior. So we find that patients that have aggressive or get agitated, especially with sundowning, there's usually some trigger. It may be time of day, it may be some person, it may be something, but try to figure out what that trigger is and reduce their exposure to it. And then you want to get these folks into the community support service. So contacting different local services that may be able to come in and sit with the patient so they're not so socially isolated, offer some services, some respite care to help the caregivers. And then goals of care, you want to provide an environment with minimal failure and maximal use of retained ability. So if you can manage these patients at home, living independently with caregivers coming in, that's exactly what you want to do. You want to keep them functioning as maximally as possible, but you do want them to succeed. So as they start to fail, maybe that independent environment, maybe they need to go to assisted living if that's appropriate, but you do want them to keep doing as much as they can. You want to limit transition. So going from home to emergency room to hospital to skilled nursing facility or rehabilitation facility really does cause cognitive decline. And we typically hear care partners say, you know, once they went through that hospitalization stay and rehab stay, they just haven't been the same. So we like to limit those transitions as best as possible. You want to set a treatment plan and try to stick to it unless you need to modify it. You want to simplify medication. So every medication needs a justification. I usually say 50% of my job as a neurologist is to get rid of medications that the patient probably does not need, or probably doesn't notice that they don't need to be taking anymore. Pharmacies can pack up things, their medications in blister packs, which makes it easy to see if the patient is missing medications, or, did I take my medications this morning? They can easily see in a blister pack. And then reduce the number of drug passes. So how many times a day are they taking these meds? Can they get by with one time a day? And that will reduce error and caregiver burden. And then lastly, I want to just spend a few minutes talking about care partners and caregivers, because care partners, 2/3 of them are women, and 1/3 are daughters. 66% live with the person living with the disease in the community. And so they're oftentimes about the same age. If they're a spouse, they may be dealing with their own medical concerns and issues. And so although you don't have to take care of the care partner, if they're not your patient, inquire are they okay? Do they need respite care? Because you may be able to get some services such as respite care, adult daycare, under the premise of the patient, the one living with the disease that you're caring for, to help out the care partner. But encourage them, if they're not your patient, encourage them to maintain good contact with their primary care physician to make sure that they stay healthy and they can take care of the individual they're caring for. It's interesting that there's disparities in care partners as well as diagnosis and treatment of Alzheimer's disease, but so Black care partners provide more than 40 hours of care per week than white care partners. And Black care partners are 69% less likely to use respite services and reach out to use other community services. So just be aware of those disparities. And Black care partners are more likely to report positive aspects of care partnering than white care partners do. And so just know that care partners are under a high amount of physical and emotional stress. It is not an easy job by any sense of the means. So if you can just check on them to make sure that they're getting care, that's all appropriate. And that's all I have for you. So we have about 10 minutes or so for questions. So I think I can answer them in the chat, or I'm hoping maybe you can unmute yourself and just ask any questions. Is that fair?
Yes, thank you. That was a wonderful talk. Thank you very much, Dr. Purcell. To the audience, we're going to have a slide we'll put up here about our evaluation survey to obtain your CME credit, and then we can go forward from there to look at any questions.
Hey, Dr. Purcell, that is an excellent presentation. This is Dr. Santos. Thank you very much for this excellent presentation and great review of dementia. And thank you to Dan Stewart for providing all your references for this wonderful talk. I am probably part of the 54% worried about dementia. Mm-hmm. And I'm really elated to know that the evaluation and follow-up with dementia patient is as good as in person. That's why that's why we're having this talk regarding telemedicine. But what do you think are the barriers and issues that we have to keep in mind in delivering telemedicine among patients with dementia?
Yeah, so those barriers really came to light in about March of 2020, right? So I started setting up telemedicine networks in 2011, and I was connecting hospitals like the spoke and hub model. But then, and interesting, there were challenges, right? All sorts of technological challenges. There would, not be enough bandwidth to get video signals. And then when 2020 came, it became very apparent that the older generation, so people that are older than me, because I'm midlife, they had technological challenges even more so. A lot of them didn't have internet. A lot of them didn't have a device that they can connect to. And so trying to do telecare, I love telecare. Well, I should say visual audio, so that I can see the patient in their home and I can see how they're functioning in home. It's really great. But a lot of them couldn't figure out the devices. They would have to have, a son or a daughter that can help them connect. And then they had difficulty hearing. Right. So I could be screaming, and if the device doesn't go any louder and they have a hearing deficit, I would need someone to sit next to them so that they can kind of scream louder in their ear. So things like that, and a lot of them had visual difficulties. So sometimes they couldn't see the screen, couldn't see what I was trying to, like I show them how to do the exam and things I want them to do, and they couldn't see them. So those are some of the technological challenges. But the big one is just getting people connected with internet. There's still a lot of areas in the United States that are not connectable. Alaska is one of them. And we've been having discussions with the state of Alaska to try to get good internet connection there so that we can get them connected. So I hope that answers your question.
Is there anyone else from the audience that has a question? You guys are, feel free to raise your hand or you can unmute.
No, I do want to say I appreciate you guys putting all this information in the chat. This is amazing. Awesome.
Dr. Stewart is the best. I would love to say that we need to like copyright this idea, because every time someone sees it, they go, I want to steal it and do that. And you can steal the idea, but you can't steal Dr. Stewart.
It's great. I do appreciate that. I didn't even prompt anything. I did not send anything like drop these in the chat. So perfect. Great.
Yeah, that's part of what we do with our echoes, and we love to have that. I guess your talk was really great, and it really engaged us in a lot of different ways. And I'm happy that you put in the slide there about how many people want to know about their symptoms, because I would want to know, but I can think about the older people that I take care of and the older people in our family. And I feel many of them would be highly reluctant to want to do any sort of testing. Have you experienced that as well? Because I would say that it could be that they may want to know, but they may say they want to know in the survey, but, actually getting them to the doctor, even for a flu or cold or anything, even a broken arm, I don't know if I could get them to the doctor sometimes, and then say, I want you to go and do a cognitive test. Have you seen sort of issues with?
Yeah, actually, so our facts and figures report in 2023 was just on this subject. So what the survey showed is that individuals are not having these discussions with their primary care physician. They would rather talk to their friends and compare notes to see if what they're experiencing is normal, rather than talk to their primary care physicians. And the surveys also show that primary care physicians generally wait for the patient or a loved one to bring it up. And so we're encouraging primary care and patients to make this a normal part of every routine visit. Hey, how's your memory? And then if they say, my memory's not good, you can bring them back for a comprehensive care planning visit for an hour and, evaluate them at that point. So we're encouraging, have these discussions, make it a normal part, because they're worried about a stigma. So when you ask the patients why they're not discussing it, they worry about being stigmatized. They're worried about getting the wrong diagnosis. They're worried about getting a diagnosis that's as serious. And they're also concerned that maybe their doctor will jump in and just want to give them a medication without, is there any lifestyle changes I can make? Is there any diet or exercise? And 40% of dementia can really be the risk reduced and delayed if you just engage those modifiable risk factors. So there's many things that we can do.
What would we say to our family medicine doctors who may be offering telemedicine to their patients? Maybe they know that those patients, like you said, that they're probably high risk, or they have they're seeing things. What can they do to better prepare themselves to do some of these evaluations over telemedicine or through telemedicine?
Yeah, so I recommend having at least a cognitive screening tool in your back pocket. So knowing one that your go-to, and it could be the mini cog where you give them, 3 words to remember and then have them draw a clock. But on the patient's end, they really need a piece of paper. These things are still largely pen and paper. We do have some electronic integrated into the medical system, but those electronic ones still are not widely used, and they have variable validation data. So I tell the patients, my staff knows when I'm seeing a patient with a cognitive concern, that they need to have a pen and paper so that I can have them do some of this stuff there at home, and then they can hold the paper up and show me.
Well, we really appreciate that we were able to get this talk out, and this will be recorded, of course, and on our TexLa website later on. Thank you for your participation. We'd like to present you, Dr. Purcell, with the prestigious TexLa TRC Challenge Coin for the wonderful webinar today and all of your important work in shaping the future and advancing the quality of dementia care. It was very pleasurable to have you, and it was a great talk. We want to spotlight some other events as well. Our next Project Echo webinar will be later this month on Thursday, June 22nd. We will hear policy updates from Tracy Spinner of Goodside Health following the end of the 23 Texas legislative session. In addition, there's an Alzheimer's Association Caregiver Conference that is happening next Friday, June 16th from 9 to 12:30. Both of these events are free, and you can register for the events right now. The links for them are provided in the email you'll receive for this session's evaluation. And of course, they're on our screen right now. You can kind of find some of that information. Thank you all. We'll see you at our next event. Have the great rest of your day.